Good morning, everyone. It's an honor to be here today with you. My name is Diana Maria Vallejo, and I'm currently a member of the Urology Cheat Sheets team. I have no conflict of interest to disclose for this presentation. Today, I would like to give a short introduction of the updates on indications for lithiasis surgery according to the current guidelines. To approach the scenario, I would like to focus on answering two key questions: who requires surgical intervention and what is the most appropriate treatment. For the scenario, emergency cases where a patient has a stone in the context of a urinary infection, possibly septic, or with compromised renal function. In both of these cases, we clearly need to perform an urinary diversion to prevent or minimize complications. The second critical question is what should be done. Urinary decompression can be achieved either through ureteral stent or percutaneous nephrostomy. Studies comparing these approaches generally demonstrate that both are effective. However, each comes with its own set of pros and cons. A systematic review by Hinojosa Gonzalez compared the use of ureteral stents with percutaneous nephrostomy. Their findings showed no significant differences in efficacy, complication rates, or impact on quality of life. However, the study did demonstrate shorter hospital stays in the ureteral stent group. This result contrasts with those from another study which found that urinary symptoms such as increased frequency, dysuria, and hematuria were more pronounced in the ureteral stent group. Both meta-analyses found that patients with a nephrostomy tube experience a longer hospital stay. Overall, when deciding between a ureteral stent and percutaneous nephrostomy, we can conclude that both methods are equally effective. The ureteral stent typically results in a shorter hospital stay, whereas percutaneous nephrostomy is associated with fewer urinary symptoms. Now, let's move on to your second scenario, patients with a stable renal colic. For these cases, we will address the same two questions: who should be considered for surgery and what is the most appropriate technique. In the case of ureteral stones, we need to assess the likelihood of spontaneous passage, whether the pain has been controlled, whether there is a persistent obstruction or renal insufficiency. We know that as a stone size increases, the spontaneous stone passage rate decreases. Additionally, stones located further down the ureter have a higher chance of spontaneous passage. According to the MIMIC study, stones larger than 7 mm had a 47% chance of passing if located in the lower ureter, but only 14% chance if located in the upper ureter. In contrast, smaller stones had an 89% chance of passing in the lower ureter, which dropped to 71% when it's located in the upper ureter. And after adjustment, stone size still predicted spontaneous stone passage. Now that we know who should be considered for intervention, the next question is what approach to take. The decision will depend on individual patient factors, including the stone location, size, number, and density, as well as comorbidities and the patient anatomical features. For guidance on this, we will refer to the 2024 update for the European Association of Urology Guidelines. For both proximal and distal ureteral stones, we can choose between URS and SWL. While both generally have similar stone-free rates, URS tends to be more effective for larger stones, particularly those larger than 10 mm. This applies to both distal and proximal stones. Of course, other factors should be also considered. However, the recommendation is to initially opt for URS for ureteral stones larger than 10 mm, regardless of their location. In cases of larger proximal ureteral stones, for example larger than 15 mm and or impacted, a percutaneous antegrade approach may offer better stone rates compared to a retrograde approach. On the other hand, if the stones are less than 10 millimeter, both options are equally viable, URS or SWL. It's important to note that while URS is associated with fewer retreatments and secondary procedures, it also has longer hospital stays and higher rate complication, though most are minor. But SWL is associated with lower morbidity. Now let's turn our attention to the approach for managing renal stones. We should consider the same key question as before. Surgical indication for patients with renal stones have no change significantly. This includes growing stones greater than 5 millimeter, stones in high-risk patients for stone formation, obstruction secondary for a stone, or stones causing symptoms such as pain or hematuria. Other considerations include the patient comorbidities, preferences, or particular cases that may pose risks, such as certain occupations. Now let's discuss what to do in a field scenario for stones located in the renal pelvis or the upper or middle calyx. It's crucial to determine their size. This is important because while the efficacy of PCNL is minimally affected by stone size, stone flow rates after SWL or URS are inversely proportional to stone size. For stones larger than 20 mm, PCNL definitely provides better outcomes in terms of stone flow rates. As a second line option, RIRS is gaining increasing attention due to advances such as endoscope miniaturization, improved deflection mechanisms, enhanced optical quality, and more powerful laser, for example, high-power laser. However, RIRS is not recommended as a first-line treatment due to its low stone flow rates, although some studies showed comparable efficiency. Staged procedures are frequently required. An exception for this recommendation will be patients for whom PCNL is contraindicated. In complex cases, PCNL often requires the creation of 2 or more tracts to improve the stone flow rate. However, as the number of tracts increase, renal parenchymal injury worsens, and the risk of complications also rises. To improve stone flow rate and reduce complications, a combined approach can be considered. In addition to RIRS, SWL is another treatment option. However, shockwave may require more sessions to achieve an adequate stone flow rate, and there is a higher likelihood of developing Steinstrasse, which could lead to additional procedures. The stone density, particularly if it exceeds 1,000 Hounsfield units, also affects the likelihood of successful treatment with SWL. Additionally, the skin to stone distance and the presence of hydronephrosis are important factors to consider. Despite these challenges, SWL generally results in fewer overall complications compared to PCNL and RIRS. On the other hand, for stone located in this position, between 10 and 20 mm, any of the 3 strategies could be viable treatments. Both RIRS and PCNL generally require fewer repeat procedures and result in a shorter time to achieve a stone flow rate. However, PCNL in particular carries a higher risk of bleeding a longer hospital stay. Finally, for smaller stones, less than 10 mm, both RIRS and SWL are viable options, and the choice should be based on the specific characteristic of the case. Let's consider our final scenario: stone located in the lower pole. In the stones, if the stones are larger than 20 mm or smaller than 10 mm, the approach will follow the same protocol as for stones in the renal pelvis. However, for stones between 10 and 20 millimeter, we need to take into account the well-known prognostic factors. This is because the stone-free rate associated with SWL is lower when these unfavorable characteristics are present. Therefore, in this scenario, PCNL and RERS are recommended as first-line treatment. However, it's important to consider that a challenging lower pole anatomy may predispose RERS to failure. In these scenarios, the new reusable flexible ureteroscopes have proven to be more effective when addressing difficult lower pole calysis. If conditions are favorable, any of the three strategies could be considered for treatment. RIRS has a high stone-free rates compared to SWL, but is more invasive. PCNL has an even higher stone-free rate, but it's also associated with higher complications rates and longer hospital stays. Up to this point, we haven't discussed other surgical approaches such as open or laparoscopic surgery, which remain alternatives in very limited scenarios. Advances in urology have largely displaced these procedures, and even for complex cases that might also be addressed with combined approaches. This concludes our introduction to the updates of surgical indication for stone management. I invite you to continue following our work on sharing the information we have prepared across various fields of urology. Thank you very much and have a great rest of the day.